Welcome everyone to our information session about our upcoming Lean for Healthcare course. My name is Kim Mallory, and I'm the Senior Executive Director here in the University of Louisville College of Business Executive Education Unit. Joined here by our team, Manuela Perry, Juliana Kursick, and Alex Bryant. Alex is actually our producer today and is going to be driving the Zoom mobile for us. And so you will see lots of interactions from Alex. And then we have with us Keith Leitner, who is the lead faculty for our Lean for Healthcare course. And Keith is going to give us a great overview of the course that's coming up in March. We're really pleased to be working with Keith on Lean for Healthcare and some other Lean programming that we are doing with him. You all received his bio as part of the registration confirmation, so I won't go through all of the details there, but Keith comes to us with over 30 years of experience working in operations excellence, spanning from the automotive supplier industry to healthcare and leading Lean for Healthcare initiatives with hospitals and health systems all across the globe. You will hear as he goes through the information session the kinds of work and the kinds of institutions that he's worked with in teaching them and helping them implement Lean in their patient care units, and the incredible results that some of these institutions have seen because of this work. So Keith, I won't belabor it anymore. I will turn it over to you. Thank you so much for doing this, and I'm looking forward to hearing what it is that you're going to say.
Oh, thank you very much, Kim. As Kim said, I as well, I'm very excited to be here. I'm very excited about this course, and just very excited about what Lean for Healthcare can do for you and for your organizations, and being able to share some of that with you. You know, it's funny when Kim mentioned that I have over 30 years. I started doing the math in my head, and it's well over 30 years. Those of you doing the math at home, I started when I was 3 years old, so we'll just go with that. But this year marks the 20th year since I have been working with Lean Healthcare. So I started working with healthcare organizations in 2005, and it has been the vast majority of the work and the teaching that I've done for the last 20 years, just simply because I think it's that important, and therefore it's something that that drives me. So what I want to do today is start with a brief overview of what is Lean Healthcare, where did it come from, so forth. But more importantly, what I'm going to do with the next 40 minutes or so is walk you through the course that we have coming up March 17th through the 21st, and how the course flows. And then most of the presentation are examples where previous students, working with the knowledge that they've gained from the Lean Healthcare teaching that we do, have actually implemented changes and driven significant improvements within their healthcare institutions. And hopefully I'll be doing that in a large variety of areas so that it'll connect with each and all of you who are watching. So Lean for Healthcare, I thought it most important to start with the definition of Lean Healthcare. And so Lean Healthcare is the application of concepts, tools, and management prescriptions aimed at furthering the organizational mission by strengthening operating processes. There's a lot there, but the most important thing, and the reason why I wanted to point this out, and I specifically highlighted, is the reason for Lean Healthcare is to further your organizational mission. The goal of Lean Healthcare is not to be lean. Lean is not an end unto itself. Lean is here strictly for helping healthcare organizations further their mission. And you know, the mission of healthcare is so vitally important. In most cases, the mission within healthcare is to provide prompt, proper medical care for all who seek it. And we know that basically healthcare has been and continues to be a growth industry just based on the demographics of the United States. There are a lot of baby boomers that are aging, and as they are aging, they're requiring more healthcare services. Yet this is being done in an environment where healthcare is struggling to be able to provide the capacity for those services, and struggling with declining reimbursements and so forth. So Basically, though, the most important thing to remember here is that the mission is first and foremost. The mission of healthcare is first and foremost. So, what is lean healthcare then doing for you? It's helping you further that by eliminating and reducing the things that get in the way of you providing that mission. It does that by recognizing that the mission of healthcare is provided through basically a series of what we call operating processes. So a process is a sequence of events linked together that deliver some type of an end result that is seen of value to the customer, in this case, in most cases, the patient. So these operating processes are how we deliver the care and therefore satisfy the mission. So then what is lean healthcare? It's concepts and tools and management prescriptions that allow you to do those processes better and therefore satisfy your mission better. So the course that we have coming up March 17th through the 21st is, I think, a wonderful course. It's a 4.5 day course starting first thing Monday morning, and it'll end around lunchtime or so on Friday afternoon. And this is basically the agenda, the overview for the week. I'm not going to bore you by going through each and every segment here, but the course has kind of got three major components. And so I want to talk about those three major phases or components. The first phase is the first couple of days of the course. And basically, what happens in the first couple of days of the course is we baseline a healthcare operation that is in need of improvement, and it's very clear that it's in need of improvement. But it's also very clear that this baseline, this simulation that we run, mimics and mirrors a lot of the healthcare institutions that our students are currently working within. So we baseline that with a physical hands-on simulation starting up first thing Monday morning. Now, this simulation is in an emergency department environment, and that's not by mistake. The reason why we use an emergency department environment is because of the specific challenges that are there that make it one of the most difficult environments to provide care to all who seek it. The whole concept of lean, as Kim mentioned, I got my original start not in healthcare, applying lean in manufacturing industries, and that's where lean began. And basically, manufacturers, they have a somewhat controlled environment. They control the pace of the work. They try to limit the scope of the assignments of the folks within there. It's very repetitive and it's more or less consistent. Well, an emergency department is kind of the exact opposite of all of those. Typical emergency department does not control who comes in, when they come in, and when they come in for from a patient perspective. Yet it's expected to have the proper capacity to be able to handle that in a very safe environment, handle the mission in a very safe environment, and do so in a world where we don't have the ability to throw tons of extra resources at it. So it needs to be properly capacitized. And then add to that, it's the front door to most hospitals. And so, therefore, the first impression that patients get is from the emergency department. So, we start off the Monday with an emergency department, a simulated emergency department. The students take on roles and they physically treat patients through that environment. And we capture the key statistics of how that emergency department performs. Then what we do with the remainder of the first day and into the early part of the second day is we teach what are called the foundational tools of lean. So these are the tools that, if you have any experience with lean and maybe attended a lean manufacturing course at some point in time, these are the same types of tools that you would have gotten in that environment. These are obviously taught specifically from a healthcare environment, but the tools do carry over between both of those two environments. And these tools are taught by lecture and education, by examples similar to the ones I'm going to be showing here in just a few minutes, and by practice. So the students working in small groups get to practice utilizing these tools. So that continues on into the second day. And then the interesting part is at the end of the second day, the students get to actually deploy those tools to the simulated emergency department and see if they can't improve the way that patients are treated in that emergency department. Then we rerun the simulation and we evaluate basically how they performed with the same metrics that we had from Monday morning. When we move into the middle part of the week, we change gears into what we like to call the lean flow tools. Now, these are tools and techniques that are very healthcare specific. So these are not tools and techniques that you would have ever received in a lean manufacturing environment. And these are the things that deal with those things that are specific to healthcare and make healthcare that challenging. So we talk about things like queuing theory, we talk about things like theory of constraints. And again, this teaching is done through a series of lecture and education, as well as examples and simple exercises that the students can work on to be able to understand the tools and the techniques. And then it culminates into the fourth day where the team once again redesigns the simulation, now building on what they learned with the foundational tools to include these lean flow tools. We rerun the simulation a third time and again show the benefit that was achieved by doing that. The final phase of the week is when we then change gears. So the first part of the week, we've learned the foundational tools and the lean flow tools, and we've applied them to a simulated environment. And it's all geared to be able to teach the students how to then go deploy these tools and techniques within their own organizations and facilities. So the final part of the week, we change gears into that specifically. So what we do with that part is we spend some time on targeting. So you have limited resources for making improvements. Obviously, you want to do that in the environment where you can have the biggest impact. So there's some discussion and information and tools given on how to target those types of things. There are additional case studies that are presented showing how teams following this education have gone back and applied these tools and these techniques and improved healthcare in their areas. Again, I'm going to be showing some of those here in just a second. But then what makes this course, I think, particularly unique is all during the week and then culminating on the final day, we're assisting the students with actually scoping a project that they will do, deploying these concepts and tools and philosophies and techniques at their own home institution. So the students walk away from this with everything they need to have the knowledge, to have the confidence, and to have the toolkit, as well as a scoped project that they can go back and actually make a difference in how healthcare is delivered within their own institutions. So they can go back then and create examples similar to the ones I'm going to show here. So I wanted to show several examples of healthcare, lean healthcare being applied in several different environments so that whoever's watching this, maybe you will see something that speaks to your particular environment. So hopefully I've got a wide enough variety there. But I can tell you in 20 years of doing this, this has been applied in virtually every environment within healthcare and has been applied effectively within every area of healthcare. So I want to start with emergency department examples for the same reasons that I talked about a little bit earlier. It is one of the more challenging, if not most challenging areas to deploy lean healthcare techniques. So this particular example that I want to talk about, a couple slides here, was a very recent example. So this was done late last year with a relatively high volume emergency department. So there are 85 to 90,000 patient visit a year emergency department. And they had what they called a rapid care area for their low acuity patients. But the metrics with regard to that were not where they needed to be. The median length of stay, which was their key metric, was 139 minutes. So 2 hours and 19 minutes for low acuity patients is very high. And that's over a 12-month period of time. And we started with the low acuity patients because we felt like, again, the mission of healthcare is to treat all who show asking for care. There are people that will argue low acuity patients maybe should not be in the emergency department in the first place. But at the end of the day, the mission of healthcare, you're going to treat them. So if you're going to treat them, what you really want is a very targeted, a very um, low resource, specifically designed to get these patients in and out and decompress basically the rest of the emergency department for the sicker patients. So the first thing that the team did, and you see the picture of this here, is we mapped the process to say, how does the rapid care area work currently? And what's interesting is you see in this, all of the yellow stickies with red circles, those are all patient handoffs and or patient waits. And so a lot of that was what was contributing to this 139 minutes and forcing basically this hospital to use 8 to 10 rooms to be able to treat these patients. This also resulted in frequent congestion at triage because all patients were expected to go through triage, and these low acuity patients possibly could avoid triage if we do something to make that happen. So the team redesigned this process, and some highlights from how they redesigned it started with the very first step. So once patients get to the registration desk, they have a quick registration. Then in the previous process, all patients would then go through a vital signs and to the triage area. But what the team did is they put a healthcare provider there at the quick reg to ask enough questions there to basically determine, are you someone that could be one of these rapid care low acuity patients? We'll peel you off this direction and you skip the triage because you don't need the triage, and we will send you directly to this low resource, high utilization, low acuity patient care area, thereby decongesting the triage area and so forth. So we direct them to basically a subset of the emergency department that's specifically designed for these low acuity patients. That also had the additional benefit of eliminating some of those waits and handoffs. So the team decided to use basically 3 rooms. In the photo on the left, you can see the entry door to these 3 rooms. I've got pictures of the rooms here in just a second. And to the right down there were these chairs, which is basically a low acuity waiting area if we need it. But we took these 3 rooms because they were close to the entrance and exit, and we felt like we could design them and basically supercharge the low acuity patient treatment area. These were pictures of the 3 rooms. Basically, there's 2 treatment spaces on the left and on the right. What's interesting here is most of these patients are vertical, and we want to keep them vertical. A lot of times, and most, if anyone's out there and works in the emergency department, you know, once you get a patient in a bed, it's kind of hard to get them out of the bed. So these patients don't need a bed. So they took the beds, pushed them against the wall to where they basically became chairs so we can keep them in a seated position. If they need to lay down, we can do that. If they needed some type of procedure, stitches, stitch removal, or whatever, we created a procedure room directly in between them. So basically, there's 3 rooms now dedicated to these low acuity patients. We also changed the way that the care was being provided there. And what we did is, this is a picture of the doctor on the left, the nurse on the right. They go in together and assess and treat the patients at the same time. This saves handoffs, it saves waits, and it saves the patient from answering the same question multiple times. There's a lot that can be done by linking these 2 together. So basically, these team assessments happen. The patients at that point are either discharged, or it's possible that they need some type of ancillary. They need a lab or they need an x-ray or so forth. Large portion of these patients need x-ray. So we set up an x-ray room. We basically converted a patient care room to an x-ray room there in the emergency department. And the patients are walked over to this chair for the x-rays to be done, or lab samples are drawn or whatever. But once the x-rays are done, or if lab samples are drawn, these patients are then moved to a results waiting area. So they're not tying up the rooms, they're not tying up the beds or the chairs in this particular case, yet they're not being forgotten either. They're in this designated area waiting for results to come back. Once the results come back, they're moved to these discharge spaces, which were basically spaces that weren't being utilized at all. So by doing this, the very first trial that the team did with 21 patients, they reduced the length of stay by 14%. And that's impressive in and of itself, but actually it was significantly more impressive than that. The last three patients that got into this low acuity trial were right at the tail end of when we were going to cut the trial off. And the team had not designed a really good handoff there. And so those three patients had a length of stay of 191-minute average. If you take those three patients out, basically the length of stay was 107 minutes, which was a 23% reduction. If you further take out the patients that were radiology patients, and I say this because that became the focus of our second project there, the length of stay for non-radiology patients were 46 minutes. So significant reductions from that. What's interesting is this was put in place, started in late September. We worked through these trials in October, and November was the first month that it was fully implemented. And in the month of November, their patient satisfaction scores hit a record high. It was at 19 to 20 points compared to the previous year, and was at a level that this emergency department had never achieved in its entire lifetime. So these are significant patient satisfiers. And the key thing is, again, these patients, which is a high volume of patients, were seen in 3 rooms, where in the past they were in 8 to 10 rooms, and done. And that basically freed up several rooms now for higher acuity patients, which is really what you're looking for. So what I want to do now is switch gears a little bit away from the emergency department. And I want to talk about starting with an emergency department, but then working with how that emergency department is connected to the rest of the hospital. So at the example that I just showed, that was one of the things we did. The second project that was done there was working with CT scans and radiology patients, again, for that connection. But I want to show this one because this is over a 3-year period, a very large volume hospital, to show you how the work that you do can lead to significant improvements from a patient care perspective. And then I want to leave the emergency department and support areas and talk about other areas within hospital systems that have deployed these concepts and some of the examples from there. So in 2022, started working with some students, went through this education and started doing basically a 3-year project, 2 separate improvement activities, and we're evaluating this over a 3-year period, basically the same 12-week period, 3 separate years. Now, this is a very large volume hospital, 130,000 patient visits a year to their emergency department. And what I want to show here is similar to the previous example. The first project that was done there was with low acuity patients. Again, designing a process for low acuity patients with the goal of getting them in and out and decompressing the rest of the emergency department to make things better for them. So the numbers that I'm showing here is a 12-week period of time looking at discharged patients. So we don't have patient holds and admission process, so just specifically treat and discharge patients. But these are ESI 2 and 3. So these are patients that would not go through the fast track area or the low acuity patient areas. These are high acuity patients. So these are the patients that you absolutely do want to be treating in the emergency departments, do need to become in emergency departments. We're going to look at how working on the low acuity patients allows us to better treat these high acuity patients. So ESI 2 and 3 patients over a 12-week period, and we're going to compare the same 12-week period 3 years in a row. So you see the volume for these patients and the metrics: total length of stay, 423 minutes, and they struggled with leave without being seen. That's the last 2 things down there. They sometimes saw as high as 12 to 15% leave without being seen, but over this 12-week period, it averaged to 5.6%. So the team decided first, let's work on the ESI 4s and 5s, these low acuity patients that we want to get in get out. And if we can do that in a resource light fashion, it frees resources for these ESI 2 and 3 patients. So as similar to the previous map that you saw, the previous example, this top part of this was the process map for how the fast track patients were treated before we'd made any kind of improvements. The bottom is showing, well, this is what we really want to move to. And you notice that it's significantly less complicated. It's specifically designed for these types of patients. The team then went and changed the several of the rooms to make them, as you saw in the previous example, specifically designed to treat these low acuity patients. And so they set up several intake rooms. There was a procedure room, there was a pelvic room, and you see there was lab stations, there was a radiology station, and you have a results waiting area and separate waiting room. So this was put in place starting late in 2022, worked through multiple trials. It's very difficult to put these kind of big changes in place in 130,000 volume emergency department. You know, the joke is it's like it's rewiring an aircraft at 30,000 feet while it's flying. So lots of trials before it actually was implemented. But we move 1 year forward to 2023, the exact same 12-week period of time and the same patients, ESI 2 and 3 patients that were discharged, and you see that volume actually increased 11%. So by decongesting the emergency department and getting these low acuity patients in and out more quickly, it allowed us to increase the number of ESI 2s and 3s that we could see in the main emergency department by freeing the resources to be able to do that. And those patients, even though they were not specifically targeted by the improvement activity, we saw reductions in their length of stay of 6%, so 423 down to under 400 minutes, and a leave without being seen rate that decreased. So it's significant to say here that not only were there decreases in length of stay, this was in a time period where we saw more than 11% additional volume. The team then chartered a second activity, which was working on those patients that are within this category of ESI 2 and 3, but also ESI 4s and 5s and so forth. So basically all patients, any who needed a CT scan. And the reason why we targeted that is because when we looked at the CT scan metrics, what you see here is the orangish line is when the CT scans for these emergency department patients began. But the blue colored line is when the emergency department ordered the scans. So what you see is there's a period of time right here in the middle where the number of scans ordered outpaces the number of scans that the CT department was able to do. So what happens then is length of stay in the emergency department starts increasing. And it's not until the end part of the day that they're able to start increasing the number of CT scans that are being done and kind of burning down that wait. But patients at this point have waited a long period of time. So the team went to work specifically on the CT scan process as it's connected to the emergency department. And so similar type of thing, this is a cross-functional team of people that were together. They were educated in these concepts that we're promoting here with this course that we're offering March 17th to the 21st here. They were educated in with these concepts in that course. And then you see on the back wall behind them was the map of how the process worked. And then this is the team working together to figure out how do we want the new process to work. What's important, you can't tell this in this team, but this team is made up of people from the emergency department, several different functions within that, from the transport department, from CT and radiology, also from lab, because a lot of these CT patients required some lab tests to be done before they could go to CT. So this is a cross-functional team working through how do we want to redesign this process. Went forward, redesigned the process, and I love showing this chart because this is showing the results of the first trial that they did with this new CT flow from the emergency department. The top graph shows the Tuesday, the day before the trial. So this is normal business. This is the way CT scans typically were working before we did any kind of intervention. And what you see is each of these bars represent the length of time from order to complete. So from the time the emergency department says this patient needs a CT to the time the scan has been completed, and the emergency department then knows what disposition to do with these patients. The bottom chart shows the first day of the trial, and same number of patients, basically 22 patients or 21 patients, but you see just drastically different results there. And it cut almost 90 minutes off of the average order to complete. So that's basically 90 minutes of time that's saved for these patients languishing in an emergency department bed waiting for their test to run, because the emergency department can't do much with them other than take care of them and see to their needs while they're waiting. So fast forward 12 months later to that same 12-week period at this hospital, looking at the same patient population, discharged ESI 2 to 3 patients. And what you see is a significant improvement again in the length of stay. So an additional 15%, so over 20% of the total length of stay between the 2 years for these patients, again during a time that volume is increasing. So these length of stay improvements are not happening during a time of low census or low volume. They're happening during a time when this emergency department is basically free in capacity to treat more patients, and they're capturing patients that normally would have left without being seen. So again, this is showing how these types of projects, building off the education that these students are getting in this course, are able to deliver for their organizations. So now what I want to do is I want to move to some other types of hospital-based examples, but not emergency departments. So this one specifically was more in support of inpatients. So a large number of inpatients at this particular hospital needed to have an echo study done before they felt like they could be discharged. So echo studies were ordered, but there was a long wait and delays and increasing the length of stay for these patients because the echo studies weren't being done. There weren't enough being done. They weren't being done timely enough due to capacity issues. So the team was brought together, given this education, and then basically they shadowed echo studies being done. And so what these pictures show is all the step by step what was happening as people were performing these echo studies. And what we saw is that they were averaging about 0.88 studies per technologist per hour. So less than one per hour was what they averaged. And we found that the technologist was the key resource, that was the constraint resource for this operation. So when we looked at it from their perspective, we saw that a large portion of their time was waiting for the patient or leaving the room to get some of the items that they needed, or making calls to transport or to the floors for the next patient and so forth. And also for taking their portable scanner and going to these patients, which was also taking away from their time to be able to scan. So what the team did is they had a couple of spaces where they could do basically stationary scans. And for the inpatients that could come to those, they said, okay, let's design basically a supercharged process here that allows us to increase the number of scans per hour that these technologists can do. So here's a picture of the room. They changed the layout of the room. They changed the way items were located. They got rid of things that didn't need to be there, changed what was in the cabinets to set it up so that the technologists basically, for the most part, could stay in the room to do the work that they needed, reducing their motion waste. And then set up in the hallway. This is with tape. We were able to create a permanent solution after, but set up basically some parking spaces to facilitate flow so that it offloaded the technologist from making the calls to transport, making the calls to the floor. We basically have someone coordinating that flow, a transporter basically coordinating that flow so that the technologist could finish a scan, bring a patient out. The next patient that they were going to scan was right outside their room. So as soon as they were finished hanging their images, they could scan that next patient. What were the results? We trialed this 6 hours a day, 2 straight days, so 12 hours over a 2 day period. And during that time, we increased the number of patients scanned per hour from 0.88 to 1.38, so a 57% increase. And while that sounds impressive, the more impressive thing is 12 additional inpatients were able to receive scans versus their normal performance. So that's 12 additional inpatients that we now are able to move toward discharge so they can get on with their lives, get back home to their families, and we can decongest the inpatient floors. This is a pharmacy example, and I only have a couple of slides here, but this was a large hospital centralized pharmacy that basically was filling prescriptions for all of their Pyxis machines all over the hospital and in some satellite campuses. I think there were 85 Pyxis machines that they were satisfying. And so basically every single day, what was happening was they were basically downloading all of the information from what these Pyxis machines needed, the shortages that they had with regard to meds. And then they were pulling those, sorting them, resorting them, combining them. And what we saw is that from the time they ran the report on what meds were needed to the time those meds were in the Pyxis machines was up to 8 hours later. Obviously, those numbers changed during that period of time. And so this was leading to a lot of dissatisfaction on the floors and, frankly, a lot of emergency calls to the pharmacy to fill prescriptions because they ran out in the Pyxis machine prior to it being filled. So, just to show, this was the result once they changed the process around. So, what had been 495 minutes as a baseline, you see for each of the different areas, that number reduced to where most of them were less than 90 minutes. So from 8 hours to less than an hour and a half. And what this does is it moves, this is what's empty in the Pyxis machine or needed in the Pyxis machine to the machines being in there so much faster so that on the inpatient side, the people going to the Pyxis machine, there's a much greater possibility or likelihood that the meds they need are going to be available to them. I want to show some examples from operating rooms. So this is yet another major area for most hospital systems. It's typically the biggest revenue driver for most hospital systems. And it's been an area that I've been doing quite a bit of work for the last 10 years or so. So these are, again, examples from where working with students go through this training and then going and targeting making improvements in the operating room. So the mission in the operating room is to surgically intervene with patients that need surgical intervention. If you take that a little bit more finite, basically then the mission is satisfied between incision and close. Prior to incision, we're not actually satisfying the mission of the OR, and post-close, they're now in recovery, so it's not the OR's mission, it's part of the patient care. But if you look at it from an OR perspective, cut to close or incision to final close is where the mission is. So what lean tells you is everything outside of that, if you can make improvements to that, is going to allow you to spend a greater percent of your time in the cut to close and therefore a greater percent of your time satisfying your mission, furthering your organizational mission. So what this is showing is where the team identified all of the different activities that were happening prior to cut and after close or between cut and close when we're changing from one patient to the next. And each of these led to improvements that these teams then went and implemented. Those improvements were things like improving in-room supplies and in-room stock. So determining what should be in the rooms and then making sure that that is exactly what's there and only what's there. Improving the ability to get to equipment. So between before cases and in between cases, frequently equipment needs to be changed out. So looking at where people need to go to get that equipment and making it such that, as you see on the right, it's very simple to get in there, get exactly what's needed, and you know exactly where to return it. Instrumentation is a big part of what's happening between cut and close, but making sure that you have the right instruments. What we typically see is most operating rooms, they're quick to add instruments to preference sheets and pick sheets and so forth, but they're not quick to delete them. And this leads to lots of extra work all through the process. So this is just showing an example of one case where they were able to reduce the number of instruments needed from 103 to 41. And you can just imagine all the improvements that come from that. Standardization. So as we do these set up for the first case, and as we change from one case to another, one of the big concepts within lean healthcare is standardizing the work. So defining what should the circulators do, what should the scrub techs do, what should the support people do, what should the surgeons do, what should anesthesia do. And so this is where the team is defining that so that it's much more orchestrated. And things like simple visuals to show you when you are setting things up, here's how it should look. So on the right is a photo of when you close down the room at night, here's the equipment that needs to be there for the next day. On the left is a picture of this is how the back table should be set up before you wheel it into basically the surgeon area. So this is in the sterile field. And what you can't see in the picture is right up above that was a plasma screen basically with this photo. So it assists the scrub techs in setting this up, makes it easier for them, make sure they've got the right stuff set up as well. Looking at the layout of the room, so the photo on the left, the diagram on the left is showing all the movement of the people as they're setting up the room. And what's really important here is the very bottom right of that photo is the entrance door. The left hand side in the front was the sterile field. So you see there was a lot of activity right next to the sterile field, which is obviously not a good thing for a lot of reasons. And so on the right, they changed the layout of the room to move the sterile field to the back wall and significantly decongest that and make it to where it flows better and is easier to set up. Some examples beyond hospitals, so some scheduled and ambulatory, and I'm going to go through these relatively quickly in the interest of time. But this was from a mammography center that I worked with. So the students came through the training, they asked me to come in and help them with this. And so this is them looking at the process for mammography. And basically they had a long wait for people to be able to get in and have scans done. And their template was set up to 3 patients per hour, about 20 minutes, because that was what they were averaging. And at the time that they were beginning to look at this, they were afraid they needed to hire more people and or make it worse, possibly buy more equipment. But when the team looked at it, they figured out, you know, with the existing people, we can change the flow to look like this and actually go from 3 patients per hour to 4 patients per hour. So increase the volume by 25%. And if you look at this, the squares in green, that was the time that the scanner was actually being occupied. If we changed by adding one more person, someone, a support person or an admin, we could actually change that to 6 per hour. Therefore, significantly improve the access, which is the mission, but it also has a significant impact to the revenue as well. $250,000 at this particular time, straight to the bottom line for being able to treat these additional patients and conduct these additional appointments. This is from a family practice clinic and similar types of things to what you've seen. So this is the storage in the room, designing a system for that. So all the rooms are set up the same and you know consistently what's in there. Looking at the rooms themselves, what I love about this picture on the left, those were cabinets that were largely filled with excess items we didn't need. We removed them from the walls of their rooms. And the photo on the right shows when we removed that, we were actually able to set up the room to where the computer was facing the patient. So therefore the physician was facing the patient as they were treating them. Also look at scheduling. So this is a scheduled environment. So let's look at scheduling. What I love about this is you see the bars in yellow was their current scheduling system based on an assumption that they could treat patients every 15 minutes. And so you see they were systemically overrunning their capacity early. And then you saw patient, they basically filled up the waiting room and patients waited. But the red bar shows that they were actually averaging 20 minutes. And so it was even worse. And then the hashed bars, most of these patients, or a large portion of these patients, needed 2 visits with the doc. So this just shows you how they were overrunning capacity. So they were doing it to themselves. So we modified based on a drum buffer template, which is what I consider to be the theory of constraints version for how you scheduling, to a different template, which is the green bars. And you see it's much more level across the board, significantly reduced waiting, and allowed them to actually see more patients. So last slide, and then I'll turn it over to Alex for questions. As you can see, through all of these examples, these are impressive examples of things that have been done to make improvements in a variety of areas within healthcare. And it all started by cross-functional teams of students coming and receiving this course, or a version of this course. So they gained the knowledge and the confidence in the toolkit to go back and deliver those types of results. So with that, I'll turn it over to Alex for questions.
All right. Thank you, Keith. And thank you, everybody who posted questions in the chat or the questions and answer function. So the first question that we have here is the course in person or online? And I can answer that one. It is in person. At the next one is at the Student Activity Center at the University of Louisville.
It needs to be in person, and there's a lot of benefits from being in person. There's a hands-on simulation. There's teams working together in group environments, which is basically a scrimmage to what's going to happen in the real world when you go try to deploy these things.
Yes, wonderful. Okay, the next question, who should attend the Lean for Healthcare course?
Great question. Whoever has a great question. So this course is designed to take people who have heard of lean healthcare, even been involved in projects and honed their skills, all the way to people who have never even heard of lean or lean healthcare. It's designed to take people from 0 to 100, or from 60 to 100, or from 30 to 100. It's also designed to look at the business of healthcare from the aspect of the people that are actually the practitioners that are actually providing the care, up to the administrators and the leaders who are directing the improvement efforts. So we've had CEOs and COOs and CFOs attend. We've had lots of docs, nurses, techs, and really it spans the gambit. And it's designed to facilitate the learning for any environment, as long as you're working within a healthcare system.
Okay. The next question, is it okay to attend the course as an individual, or should team members take the course together?
It is okay, obviously, to attend as an individual, and you will gain quite a bit. You'll be working in teams with your students while you do that. But a lot of the examples that I showed, and some of the more successful things that we have seen over the years, is when an organization has sent a team of 2 to 5 people through this course, so that they're learning together and making the connection to their own organization together. And frequently, when they come to the course, it's already been identified for them the target area that they're going to be working on when they go back. So they use the course and they use the time with the faculty to, again, scope that and hone that in.
Wonderful. Next question, after attending the course, will I be able to go back and apply what I've learned and make a difference? Will I need any additional support?
So we feel that you absolutely are equipped. We feel that we are giving you the tool set, we are giving you the philosophy and examples such that you are equipped to go back and actually make a difference. And we've seen that happen numerous times, and we love that. And a lot of times we'll have students that will just reach out to say, hey, by the way, here's what I've done. Thank you so much. And we love getting those types of things. But we also see a lot of times that students feel like they're equipped, they're knowledgeable, they have a much better idea of what needs to be done, but they're feeling a little bit lacking in the confidence to be able to do that, because this is something that's new to them. And so we have the ability to support that as well. We can support that with on-site support, facilitation support, or virtual support, actually helping the teams through the chartering process, through the planning phases, through the implementation phases, and even the follow-on and next step phases. So we have the ability to be able to provide additional support, but we do feel that students, for the most part, lacking the confidence, come away with what they need to be able to do this on their own as well.
Okay, wonderful. Next question, what kind of credential will I receive after completing the course? And I can answer that one. So participants will receive an executive education course certificate from the University of Louisville. You'll also receive 3 CEUs, continuing education units, for the 4.5-day program. And we are also working right now to be certified for CMEs, and there will be 30 CMEs granted for that program.
Fantastic.
Next question, is there anything that I need to do to prepare for the course?
So the short answer to that is no, other than signing up. There are lots of good articles, research, things out there. If you Google Lean for Healthcare, you're going to find lots of things, and we would encourage you to read up on that and so forth ahead of time, but it's definitely not required. Again, you could walk into this course with zero knowledge, zero exposure to this, and leave this course ready to go back and make a difference.
Wonderful. Okay, that's all the questions. So Keith, unless there's anything else from you, I think we can turn it back over to Kim.
No, I'm just other than I'm so excited about this. Hopefully that came through in my presentation.
It definitely came through in your presentation. Every time I go through one of these, I learn so much. So thank you, Keith, for really going through not just what the course is, but all of those fantastic examples, real world examples of how this program has impacted so many organizations. For those of you in attendance, we will be sending you a follow-up email with information on the course registration. If you have any other questions, please reach out to us. And please, and I'll include this in the email that we send, you can reach out to Keith and ask him questions directly. You know, we want to make sure that you are as informed and prepared to attend the course as possible. And so Keith can be a direct resource for you. Any questions that you might have, you might take this back to folks in your unit and they may have questions that you're just not quite sure how to answer. Reach out to us and we are more than happy to partner with you for that. So expect a follow-up email from us. You'll also receive a recording of this webinar. And so you can pass that on to anybody else that you would like to see this, that maybe wasn't able to attend, but you really feel like that they would benefit from the information as they're curious about the course and how it can impact your organization as well. Alex, thank you for keeping us on track and for making sure that our systems worked great, for managing the Q&A. Keith, thank you so much for your time here. We really appreciate it. And we will be in touch, and thank you so much.